What does a pharmacist do? Well, most people might answer that a pharmacist dispenses the medications that my doctor prescribes. Now, I work with a ton of great pharmacists, and one thing that I don't generally see is excitement about pills in a vial. And this is probably because pharmacists have been trained to do so much more. So what can you get excited about in your community? To find out, let's go beyond the scripts. Hi, welcome back to Beyond the Scripts. I'm your host, Will Tuft with PioneerRx. And today we're going to talk to a pharmacist out in Kansas about a familiar journey that we see with a lot of our pharmacy leaders, where we see these leaders go through pharmacy, independent pharmacy, bench pharmacists, ownership, and really kind of identify something that they can do to make a difference in the industry. So today we have DIR Price joining us. And DIR, welcome to the show. Thanks for joining us.
Yeah, thanks for having me, Will. Appreciate it.
So you're kind of a known name up in Kansas, very involved in the pharmacy scene and CPESN. Tell us a little bit about kind of your first pharmacy gig. Where did you start on the bench at?
Sure. Yeah. So I am a Kansas pharmacist, but I grew up in Oklahoma. So I started as an Oklahoma pharmacist, graduated from University of Oklahoma in 2008, and took my first pharmacy job at an independent pharmacy in Enid, Oklahoma. It was called Sheffy Prescription Shops. Mr. Walter Sheffy owned that place. Whenever I first started there, Steve Pryor and the Osborne groups had just purchased Sheffy Prescription Shops, but Mr. Sheffy was still there, and I think he was 94 years old, still in the pharmacy, not really working so much, but he would come in there and work a little bit. So really cool story of a really cool independent pharmacy, and man, what a busy place! It was a great place for me to cut my teeth in pharmacy. On busy days, they'd fill 1,200 prescriptions or something like that. It was a very, very busy independent pharmacy, but Steve was great. I learned a lot at that job. We started vaccination services, compounding services, kind of caught the pharmacy up to speed for today's world. So I worked there for a couple of years, and then we got the opportunity to look at some pharmacies in Kansas. So these two pharmacies were owned by the Graves family, Graves Drug Stores. At one point, they had 11 locations in Kansas and Oklahoma, but for one reason or another, they had been whittled down to just 2 locations left, and these 2 locations were struggling quite a bit too. But those were in Winfield, Kansas, and Ark City, Kansas, and so Willie Osborne called me up one day and said, hey, or Willie and Bill called me up one day and said, hey, would you like to look at a couple of pharmacies in Kansas that we may partner in? And I said, well, sure. And so I went up there, looked at them. It was a great fit. I felt like great people, great communities, just kind of what I'm used to, small town America. And so I went and looked at them, came back and told Renee, I was like, well, Renee's my wife. She's also a pharmacist.
Important buy-in.
Oh yeah. Very important. She's a much better pharmacist than I am. She should be doing this podcast instead of me, actually. But anyway, I came back and said, hey, what do you think about moving to Kansas? And her response wasn't the most positive. I won't tell you exactly what she said, but since this is a family podcast, we took the leap, and went and moved to Kansas in August of 2010. So exactly 11 years ago here in about a week. And so we moved to Kansas and started in those stores. And then a couple of years ago, we decided that, we just had way too much time on our hands, didn't have anything else to do. So we decided to purchase the Dam Pharmacy Group. It's DAMM, a gentleman by the name of Gary Dam, a very successful pharmacist in the Wichita area. And so we decided to purchase his remaining stores, which were 4 locations, 2 in Derby, 1 Rose Hill, and 1 in Andover, all kind of in the greater Wichita area. So that's where we are today as far as pharmacy. And then we'll talk a little bit later about our other venture that we've started.
Sure, sure. Yeah, so you're down working in Oklahoma. How did you kind of build that connection with the Osborne Group?
Yeah, so I met, it was funny. So I was involved in leadership at the University of Oklahoma College of Pharmacy. And so I was president of my class for 4 years. And one of the invites that you get as president of your class is to the Alumni Association banquet. And so one day, Tony Palmer, I don't know, a lot of people remember him, really, really great guy, taught our business class in pharmacy school. And he, one of the parts of the alumni dinner was he just would take the microphone around and talk to people, and so he finally made his way to me and put the microphone in front of my face, and I was a scared fourth year pharmacy student, like, oh my gosh, what do I say? And so I kind of panicked a little bit, and he said, hey, what, do you have anything to say tonight? And the only words that came out of my mouth was, I need a job. And so that's how I met Bill Osborne. So he kind of approached me afterward and said, hey, we may have an opportunity for you in Enid, because like I said, they had just purchased those stores with Steve, and they were looking for some new pharmacists to go in there. And so, met with Bill a couple times and decided it would be a great fit. And, I guess the rest is history.
Nice. So yeah, I guess sometimes the squeaky wheel is
sometimes you gotta ask,
Yeah, you just got to make yourself stand out a little bit. So back in Oklahoma, you kind of mentioned that you were doing some enhanced services. I guess it was a fairly small community, even though it's a really busy store.
Yeah, Enid, I think, is around 50 or 60,000 people. So It's not near as small as, Winfield and Ark City are more like 11, 12,000 people apiece. So it was a fairly decent sized town from what I'm used to.
You kind of make that shift into Kansas. What differences did you see? What opportunities did you see? Because those stores were coming from basically a fairly small community, and you said that the previous owners had struggled a bit with keeping that legacy going. So how did you see that you could do something different in that arena?
Sure. Well, one of the things that the Osbornes, or that Willie always said was, we don't buy stores that are doing really well, because those are going to be really expensive. We look for the ones that we think we could go in there and make a difference. And so just by an evaluation, and I'd say the evaluation of stores are a lot different today than it was back then even. But when doing the evaluation, you just look at other things that you could be doing in the community. One of the things, as I mentioned, this was owned by the Graves family, and so it started back in '47. And so Mr. Graves, owned it for a really long time, and then passed off to his grandchildren eventually. So the owner that was in charge of operations was actually the granddaughter of Mr. Graves, who started it. And she did a great job, wonderful woman, and so she did a great job for a long time. But I think there's some value in being a pharmacist and owning a store, and so she was not a pharmacist. And so, I tell people it's like me trying to run a hardware store. Like I wouldn't know the first thing about running a hardware store because I just haven't grown up in that industry, and I don't have experience in that industry. And, there's just certain things you learn along the way from being a pharmacist that you can find that would be successful. So that was one of the things that we thought we could come in and immediately change is, adding some services that we have learned, that I got to the opportunity to learn at Sheffy's, such as immunization, such as compounding, MTM, all the other stuff that we do as pharmacists besides just dispensing medication. So, and then that partnership with the Osborne Group, has always been a wonderful thing. They're great people. And they are a partner in 30 different stores or 29 different locations, and so that added some buying power and some things like that to that as well.
Yeah, absolutely. So, I mean, I think there's definitely pharmacies out there that are owned by people who aren't a pharmacist, but definitely just moving into that situation is going to give you, some power with your funds as well. Just being able to move that around the payroll expense and having that all in one. So, definitely a lot of different areas that you could pull in some change. What about MedSync? I know Graves has quite a bit of MedSync at that location too, don't they?
Yeah. Winfield that's one of our babies is MedSync. We have a great group there at Winfield, and our really all of our locations have great people. I think that's a big part of being successful is surrounding yourself with great people. And anyway, we really made a point a few years ago to build up our MedSync program. And so, yeah, I think today we have around 850 or 900 people on our MedSync program. And it's funny, people always ask, well, what percent of your patient population do you have on MedSync? And I don't know that for sure, but I do know that we have 10% of the population of our town on MedSync. And so that's how I kind of always gauge it, is what percentage of our full population in our whole town do we have on our MedSync program. So
so I think that's kind of like indicative of just a lot of your goals. Don't just look at your patient base. Don't look at the numbers in your system, but compare that against the census and say, okay, where could we be in our community? And that sounds lofty, but that's, especially in a small community, that's, kind of an obtainable figure that you can really consume that number and look at your footprint in the community and say, okay, how do I move that forward?
Absolutely. Yeah. Any new patient that we take on nowadays, I mean, that's one of the first things that we try to get them to be a part of, because we've seen the value in it. We've seen the value of somebody being on MedSync. There's multiple reasons why, and I won't go into all those, but we just believe that it provides just a more enriched experience for our patients. And so that's part of our welcome process for our new patients, is to try to get them, encourage them to be not only on MedSync, but do, the med packaging as well. We do a bunch of that also. We probably have 200 or 250 patients that we do that for on a monthly basis in that one store.
Oh, nice.
Yeah, we have a lot more throughout our group, but yeah, it's a big point of emphasis for our pharmacies for sure.
Yeah. It always seems like just as far as workflow efficiency, before you even get to adherence metrics and patient care, but that patient's coming back every month. These prescriptions have refills. Why not sync all those medications together, have them come at the same time, get all those medications every month, and then that opens the door to do a lot of other things once you have that appointment-based model. So what opportunities have you found once that patient is coming in on a more rigorous schedule, they're taking their medications, what opportunities have you found there to take advantage of that face-to-face interaction when they do come in?
Absolutely. Well, like I said, there's multiple things. From a pharmacist standpoint, it's just so much easier to see, the clinical picture of a patient if they're all tied together. If they're getting different things at multiple times during the month, it's hard to see, what cholesterol medication they're on currently, what blood pressure medication they're on currently at what dose. But if you're tying them all up at the same time, it's so much easier to catch duplications and, look at cost effectiveness and, just all kinds of things from a pharmacy's perspective. And so I think that is very valuable to the patient and to the pharmacy. You mentioned, it saves time for patients. We've really hardly ever lost anybody once they get on the program and see how awesome it is. very rarely do they ever want to get off the program. It doesn't work for everybody. We do have those patients that it just doesn't work out for. But once they start doing it for several months, it really is a great thing for both the pharmacy and the patients. And yeah, you mentioned number one, time. It saves so much time for the pharmacy. And so that has been, exemplified, I guess, during COVID, because our pharmacies have administered over 17,000 COVID vaccines. And there's no way we would have been able to do that without great MedSync processes, because we've had to take technicians out of the workflow to administer immunizations. We've gone to 50 different businesses to do on-site clinics for them. And so we've had to pull people from the workflow to go out and do those. And so without MedSync, there's no way we would be able to do that. And now, kind of a cool program in Kansas is COVID testing. And so I know everybody's doing it nationwide, but in Kansas specifically, our state is funding the program. And so you can actually get rapid testing and saliva PCR testing done, and the state reimburses you for doing those. So no cost to the pharmacy, no cost to the patient. And man, we have seen such an uptick in those. I think in one of our stores in the whole month of July, we did 150. And in the first 10 days of August, we did about 400 COVID tests in just one location. Wow. And so, without MedSync, that doesn't happen. You're in the rat race, the workflow, trying to catch up, trying to catch your tail all the time. And, that enables you, once an opportunity comes along, that enables you to jump on that opportunity and take full advantage of it. So,
yeah, that's one of those things people don't consider. If you have a patient with just like 5 medications, they have that first touch point where they call to get the medication refill. Then your pharmacy's going through workflow. You have to call that patient to let them know it's ready. And then you have to actually have that face-to-face interaction. If you're doing that for 5 different medications, that's 100 touch points for that patient. It's crazy how quickly it adds up. And so how can you do those other, really, really impactful things like point of care testing?
Absolutely. Well, and I'll put a plug in for Pioneer. Their system has been wonderful as far as putting a program in place. We've tried. And this isn't, one thing doesn't work for everybody. You have to figure out what works for you. If pencil and paper works for you, do pencil and paper. But, we've really tried to take advantage of technology, and Pioneer has a wonderful sync program, and it's enabled us to, create templates to send text messages out to patients instead of having to pick up the phone and call every single month. And it's easy because if they have an issue, if you need to talk to them, they can just respond to that text message, and then it's a quick phone call, and there you go. So having the right software in place to be able to, match what you're doing as far as MedSync goes is very, very important.
So, you kind of mentioned the point of care testing. I'm curious to see where that kind of goes in the future. Like once you normalize something like pharmacists being able to provide point of care testing, it's made sense for a long, long time, but it hasn't really been in place. And you could say the same thing about immunizations as well. Where do you see that in 2022, 2023? Do you see more, do you see like people doing rapid tests for flu, and flu season, and
Yeah, that's kind of been our plan all along. Flu, strep, even like UTI type of testing. I think that the pharmacy is a place where that makes sense to happen. And we've been very involved with CPESN, and if anybody's not a part of CPESN, these are the type of things that we push on a daily basis. And so I think it's important to have organizations like CPESN, NCPA that really try to push pharmacy into that direction. But yeah, I mean, even before COVID started, we had talked at length about strep testing and flu testing and the UTI testing. And, people see their pharmacists, 35 times a year, whereas they see their physician maybe 3 times a year.
Right.
And so it just makes sense for somebody that, thinks they have the flu or thinks they have strep, pull up in our parking lot, let us go perform a quick test and tell them whether they have it or not, and then have a collaborative relationship with a local physician and have them be able to, prescribe for that patient at that point, and then, provide some follow up if they don't get better. So I think there's some great partnerships to be had in this space, but I'm very hopeful that we can take all the data that we are getting from COVID testing and compile that and make a very compelling case for pharmacy in the testing space.
Yeah, I mean, really, when you look at medication adherence, getting patients to take their medication like they should, removing those barriers to healthcare, like having that point of care testing at the pharmacy, that's great for the pharmacy as a business, for the patient, for staying healthy, but that also really benefits the other parties involved, like insurance companies. That's really what's going to drive down health cost. And from a business standpoint, if I'm an insurance company, man, that's great news, right?
Absolutely. Yeah. I mean, and we've been involved in programs where we're doing like A1Cs and, cholesterol screenings and things like that. And take blood pressure, for example. Think of how cool it would be if you had a patient on a sync program to where they're coming to get their medication every single month, and while they're at the pharmacy, you take a blood pressure or blood sugar, whatever, and you put that data into your system, and that data is shareable amongst their primary care provider. And so once they go to get their once a year checkup with their physician, now their physician has 12 months of blood pressure data to be able to make an informed choice or an informed decision. And not only do they have that, but they have their adherence scores as well. Because I think every pharmacist will tell you, we see it all the time. Decisions are made on one blood pressure reading once a year at the time of office visit, without any recollection or without any knowledge of, is that patient actually taking their medication? Patients will tell you all day, every day that they're actually taking their stuff, but how often do they pick it up at the pharmacy? And I would say, yeah, gosh, way less than 10%, maybe less than 5%. Have we ever been called, to ask, hey, is this person actually taking their medication? It just never happens. And so to me, that makes so much sense, to partner with somebody and have those type of readings and tests available so the physician can make a informed clinical decision.
Yeah, because patients are always going to kind of say what the doctor wants to hear. I tell my dentist that I floss every day.
Yeah, right, exactly. But whenever I go see the hygienist, I don't floss every day.
So, as a pharmacist, you're seeing kind of both sides, because you're a pharmacist, you're a business owner. And so you're performing all of these great services. You're helping to move the needle for 10% of your population at least. You're really doing all the right things. And at the same time, you're battling with the same problems that every other independent pharmacy is struggling with low reimbursements, with balancing that patient care with what's on the shelves, with reconciling your third-party payments and DIR fees. So, at what point did you see that, okay, this is non-sustainable unless something changes? What really, at what point did you see that something has to give?
Yeah, I think it was really the spike in DIR fees that maybe did it for me. I go back and look at and this just makes me nauseous even talking about it. But you go back and you look at like 2015, what your DIR fees were. And of course, we've added more stores since then, but our DIR fees were less than $10,000 a year in 2015. Last year, we paid about $1 million in DIR fees for our locations. Yeah. And so that's just unsustainable. And so, and it's sad. And that's kind of what prompted, this conversation, I guess, is it's sad for pharmacies that if you're a pharmacy and you're just dispensing medication, there's no way you can make it. 0% chance of staying in business and providing any type of good service to patients. And so every year, our strategic meeting for our leadership team and our pharmacies is, we need to focus on everything that, we need to try to do more things that aren't dispensing medication, like vaccines, like COVID testing, like, these CPSN partnerships that we've had. And so that is our main focus instead of, dispensing medication. And there's something wrong with that, so that's really frustrating. The other first frustrating part to me is, there's multiple frustrating parts, but, we pharmacy, and I don't think anybody will argue this, pharmacy are the experts on medication, not only from a therapy standpoint, but from a cost standpoint, right? And we are not utilized whatsoever in trying to save healthcare money, and so I listen all day, every day to employer groups complain and to brokers complain and to whoever complain that the cost of prescription drugs just keeps rising and rising and rising. And it's frustrating to me that I can't do anything about that. As a pharmacist, I have almost no control over that, because even if you do switch somebody, so in an NTM, a common thing for a pharmacist to do is to look at spend, right? And switch somebody from something that is just as effective, a therapeutic substitution, for something that's just as effective that has a higher copay versus a lower copay, right? So that's a common thing to do to save the patient money. But what you may be doing, you may be cutting the legs out from under the employer, because they may be getting charged twice as much on the back end for the thing that costs the patient less, if that makes sense, which is crazy. It's crazy to even say that.
Yeah. So, that's the craziest thing with prescription care in America, is that there's this whole back end that I think is just not really visible to your average consumer, and which is why the average consumer sees something like a RX Good program, to avoid naming anybody specifically, and because it's it's all of this, kind of convoluted way of, hiding the price and all of the different values associated with the drug. So if you look at one drug in a pharmacy, there's what you paid for it. There's the WAC, the AWP, MAC, NADAC. There's so many different values, and then so many different formulas that use each value. It's. I think clarity is the biggest issue for most people in healthcare right now.
Yeah, absolutely. Transparency should be one of the major things. And it is frustrating. The other part that's frustrating is legislatively, we have been beating our heads up against a wall for over a decade now, trying to educate, to, show some of the bad practices that are happening in the pharmacy benefit space. And even though there's been some great wins on the state level recently, and I think NCPA does an outstanding job of bringing those, of educating and bringing those issues to light with legislators, I should say. It's just still very, very frustrating, because you're battling a very, very powerful middleman that nobody knows about, and so
right.
It's almost an unsurmountable task, And so that's kind of what caused us to start looking at other, something else.
Yeah. So if you go to a pharmacy and just ask, somebody in the pharmacy, a patient who's walking around the front end, how insurance works, they're probably going to say, I'm here. I have an insurance company over here, and the pharmacy's in the middle. I go to the pharmacy, they bill my insurance company, and it comes back to me. I pay the insurance company $100, whatever, and they pay for whatever percent of my medication, and everybody wins. But there's a lot more to it than that. So kind of briefly go over where a PBM fits into that. And then really, we concentrate here especially so much on how that relationship affects the pharmacy. But, there's other stakeholders to consider.
Sure. Yeah. So every health plan, you want to think of it as a health plan as a whole. So there's in the health plan, there's an insurer, right? But they are contracted with the pharmacy benefit manager to manage the pharmacy spend, and so the pharmacy contracts directly with the PBM, and then the PBM's contracting with the health plan over there. So, they are definitely in the middle. The PBM, they regulate what medications are covered, what the patient pays, what the health plan is charged, and everything that has to do with the pharmacy spend aspect. So when people say it's my insurance, it's not really your insurance. They contract with a separate entity that controls all of the pharmacy spend. And the scary part, as all of us know, is now most health plans or most insurers also own a PBM. And so they own two pieces of the pie, although they say they're separate, and so they own two pieces of the pie, which is a scary position to be in.
And, as a business owner who is trying to provide adequate health care to your patients and maintain the, that quality of care for your patients, but also, control spend, for your company. So
absolutely. Yeah. And what we're seeing in the marketplace right now, Will, is every employer that I've talked to, whenever it comes their renewal time, their broker or whoever will come to them and say, okay, well, there's going to be a 10 to 15% increase in your premiums this year because of pharmacy. I mean, almost across the board, that is what we're seeing. And, it's because of the regulations, right? So on the insurance side, 80% of your premium has to be spent on care, right? There's that rule in place. So the insurance can only profit 20% of whatever you pay in a premium on a yearly basis. But there's no regulation on the PBM side, and so what we're seeing is all of the medications when you come to the pharmacy, and we don't necessarily see it at the pharmacy is also the scary part, but the amount that the PBM charges the health plan is going up dramatically, right? And so even though copays may be lowered, maybe a $0 copay for the patient, so they don't see it, the pharmacy is not being paid any different, so we don't really see it, or paying low or getting reimbursed less actually. But what they're doing on that back end is they're increasing the amount that the health plan is being charged, which is called spread pricing. And so then ultimately what happens is the premiums get increased on the health plan side. That's an excuse for them to raise premiums. So they're the PBM's not only making more money by charging the health plan more, now the health plan has to raise premium, and so ultimately they're making more money as well. So the two people that are hurt most in this scenario are the patient, even though they think they're getting a great deal with a $0 copay, and employer groups, and pharmacies. So it's a bad, how we ever got here, I don't know, but there's just misaligned incentives running around all over the place.
Yeah, I think spread pricing is kind of the key the key word there, and it's a bit of a shell game. So if somebody's not familiar with spread pricing, give me the elevator pitch on how that works.
Yeah, elevator pitch is, the pharmacy gets paid one price, the health plan gets charged another price. And so the difference in those are spread. And so most commercial plans, so anybody that's not self-insured or partially self-insured just has a cookie cutter plan from one of the big insured groups. And so whenever they go to pick up medication or at the pharmacy, all they see is one side of it. They don't ever see the other side of it. And as an employer group, you should be asking, for that other side of it. And I can tell you what the answer will be 99% of the time is going to be no. And if that's the case, then you need to start looking at some other options, because they're not telling you no for your benefit. There's some hidden stuff going on there. So that's, spread pricing at 30,000 feet is the difference in what the pharmacy is paid versus what the health plan is charged.
Right. Yeah. And patient never sees that.
No. And that's one of the guises that, mandatory mail order is a perfect example. Most people are incentivized to go to mail order, right? So if you go pick it up at, Will's Pharmacy, it's going to be $15 a month or $45, let's say, for a 90-day supply. But if you go to mail order that, the PBM owns, of course, if you go to mail order, it's $0. Well, we've seen it time and time again that the amount that the mail order pharmacy is paid is completely different than what the Will's Pharmacy is paid. So your probably total payment for that claim is going to be $45, and it's all coming from the patient. But we've seen up to, they may charge, the mail order pharmacy may charge the health plan, or the PBM may charge the health plan $1,000 for that same prescription. So we see that time and time and time again.
It's crazy. I mean, you see so many people, outside the pharmacy industry struggle with prescription drug prices, and there's a feeling of, being a victim, but it's not clear exactly who the perpetrator actually is in most cases. It's blamed on the pharmacy, it's blamed on, drug companies, but there's that whole middle piece, which is again where you touched on in CPA, where advocacy kind of comes into play. But there's also kind of like this next step that I see pharmacy leaders take it's like the most exciting step, where you go from that bench pharmacy to ownership and multi-store ownership and advocacy and precepting. And that next level seems to be like taking something that you're passionate about, identifying where you can make a difference, and then pursuing that next level goal that's going to really potentially change the landscape across the board. And that's kind of what the step that you're in now with OreadRx, correct?
Yeah, OreadRx. So I joined OreadRx, it's been almost 2 years ago now. And it was just a group of, people like me, independent pharmacy owners that were just sick and tired of the marketplace, and we think about the way independent pharmacy competes against bigger chain pharmacies is we just do it better, right? Our customer service is top notch. There's a way that you can compete against the big boys, right? And so OreadRx is a PBM that we believe that can also compete against the big boys. And, our whole driver, the mission of our company is to restore, is to use the pharmacy as a way to drive down costs for those employers. Because like I said before, I listen to so many different employers complain about their drug spend, and our hands are tied as pharmacists. But, I think it's our, not only should we, I think it's our responsibility to educate them on what's happening behind the scenes and then offering a different solution, and so that's kind of the basis of why Oread started. And man, we have some cool things that we're doing, partnering with organizations such as CPSN and local independent pharmacies to really drive down the cost of prescriptions for employer groups with honesty, integrity, and no cutting out all the middle stuff, basically.
If you are a business owner, you're at the point where finally, those low reimbursement issues, those spread pricing issues that have really kind of been contained in the pharmacy for a long time are spilling over. And, when you start seeing those pain points pop up in other areas, you start to see that awareness. So, if you are offering insurance, you do have options, right?
Absolutely. Yeah. And I think this is the way that health insurance needs to go. There are cookie cutter plans so this is a deep dive too, and we could talk about this for another hour, but you can go self-insured, you can go partially self-insured, you can go level funded. You can, ask for ASO accounts, which is, you can still have your big insurer, but you can cut out different pieces like the pharmacy benefit. Obviously, some people won't let you do that, but, some others will. So there's a bunch of different options. And, worst case scenario, you just look at it and see if it's more expensive. But the cool thing about being self-insured or partially self-insured is the money is yours. You control how it is spent. And then you can take advantage of things like rebates. Rebates is one of the biggest cost savings on the pharmacy side, that if you're just in a cookie cutter big insurance plan, you're not seeing a dime of any rebate. And so if you're looking at this, it's important to partner with a company that does not keep any of the rebate, and make sure there's just PBMs they have probably 20 different ways they can make money. And so just because a PBM tells you that you're getting 100% of the rebate, make sure that there's not 100% of what, make sure there's not an additional fee in there for accumulation and things like that. So there's a lot of different layers to unpack. But we've made some great relationships with brokers, not only locally, but on a national scale, that will come give you a quote of being self-insured. And we've seen them self-insure businesses that only have 5 employees, and so I think self-insurance sounds scary and it sounds like you're taking this big risk. But I mean, even the big insurers have, catastrophic reinsurance, and so just as long as you get some good advice from a good brokerage firm, then, you can be put in a plan where you control, all of your health dollars. You partner with companies that have aligned incentive, not misaligned incentives, and you can really control your drug spend and your medical spend. So there's definitely other options out there.
Yeah. So, I mean, if insurance clearly is a big spend, it definitely seems like getting your patients into the pharmacy, getting, any pharmacy services you can are ultimately going to save you money, because the hospital spend is really where, man, that gets expensive quick. So it seems insane that anybody would, be burdened by pharmacy coverage when it's such a benefit to really all aspects, from patient care to the bottom line and the medical spend.
Sure, and that's one of the things that we love to do at Oread is we love to marry the two. So we work with the TPA, which stands for third party administrator, and they're kind of on the health side or the medical side or however you call it, not the pharmacy side, the other side. But we want to work with them to look at, what are the pain points? Is this group spending most of their money on diabetes? Are their diabetics having to go to the ER? And is that being caused by pharmacy? Can we offer an adherence program for their diabetics that will keep people out of the ER? And so those two sides aren't married very often. No PBM that I know of besides us is doing that right now, looking at the medical spend and seeing if if pharmacy is causing it for some reason, and so and we don't initiate that at the PBM level. We work with the local pharmacy to implement these things, and we pay them to do that. Not only are we paying fair for dispensing medications, we are also paying them for enhanced services to, help their local employers, help their local school district, help their city, and so, which is the way it should be, right?
Sure. So, I mean, how does this happen? Is this one of those things where, you're a pharmacy owner, you're wearing a lot of different hats, sometimes do you just say, oh man, I better just hire the IT company, get the one that's going to take care of anything because I have too many hats to wear? I mean, is that where business owners are finding themselves? They just go with the easy option, even if it's not the best option for their employees, for their bottom line?
I think number one is you need to work with a honest broker. Your broker, we've found, is kind of the person that drives everything. And so if your broker's not talking to you about self-insurance or partial self-insurance, especially if you're if you have more than 50 employees, you should definitely be looking at this option. And if they haven't mentioned it to you, it may be time to shop brokers. Because they're the ones that ultimately lead the charge. And we've seen really good brokers. We have some good partners that we're doing business with, and we've seen some really bad ones that are making, $5 a claim on employers, and they have no idea that they're doing that. So I'd say that's step one, and then make sure that broker seeks out partners that are going to be honest and fair as well. And so, there are several different PBM options out there. We're just one of them. But there are other ones that, do things a little different than we do, but there are some good ones out there. But making sure that he looks at multiple PBMs and then just being involved in that process. I've sat in several pitches where brokers go pitch to a city or a school district, and they bring me along to talk about the pharmacy side, and their solution for saving money in pharmacy is, well, we're going to get all your members on generic drugs. That's it. That's the length of what they talk about pharmacy when they go pitch something.
Right.
And we all know that there is a lot more to it than that, and so, but it's a beautiful thing when the broker, the local pharmacist, us as a PBM or whoever, all get in a room together to talk. And then that way everything gets exposed, and so we talk about everything at length and the ways that we see that we could help solve problems.
What's interesting is that's really where PBMs were supposed to be to begin with, right?
Yeah. I hate even calling ourselves a PBM because we just, we're just a transaction. We help with the transaction, and then we try to partner with local pharmacies to, provide enhanced services that save the health plan money. Like that's, if 30,000 view of our company, that's what we're doing.
Yeah. So I imagine you guys have an interesting approach to DIR fees as well.
Yeah, so we're not in the Medicare space currently. So we're a fairly new company, and so we've only been around for 3 years now, and we haven't ventured into the Medicare space. We wanted to start small, make sure we did things the right way, because I think we've seen it a lot that people jump in with both feet and both hands, full body, and then try to swim. And sometimes it works, sometimes it doesn't work. So we wanted to make sure that we got off the ground slow and built our company up from the ground up at a pace that we thought we could still provide superior customer service, fulfill all of the promises that we make, and form some really good partnerships along the way. So we've been growing to that. We will be in the Medicare space eventually, but we haven't made it there yet.
So, so often when we talk about independent pharmacy, independent pharmacists, whether those are owners or, the pharmacist behind the bench every day in a community pharmacy, we talk about their impact on the community. And it's generally very patient centric, very much focused on that relationship. But any community, I was an installer for years for PioneerRx, and I traveled all over the country, and it seemed like every pharmacy I went to, that pharmacy owner was also involved with, Little League, with Rotary Club, with, all the different aspects of the community that they could be involved with, along with other business owners, and that seems like a really interesting way for pharmacists to help on that larger scale, is to just make sure that the business owners around them that they're sitting next to at those events, that they're networking with, kind of understand that landscape.
Absolutely, because employer groups have no idea how much they're being taken advantage of right now. All they know is, my premiums are going up because of pharmacy. That's all they are told. And if they ask to see more information, they get told no. That's proprietary. Yeah. That helps us in our negotiations. All the lies that PBMs say. And as a pharmacy owner, you got to realize that you have a gag clause with groups also, which in itself should raise red flags, right? Like you have a PBM gag clause that says you can't talk to this employer group about their prescription spend. Yeah. And so it's important to just talk in general terms, talk about spread pricing, never say, and I won't say their names now, but, X is doing this, you guys need to think about that. But, just talk about rebates and how they work, and, ask them what their PA approval rate is. If the PBM's keeping their rebate, their PA approval rate is going to be through the roof. 90% probably of PAs are being approved, because that's another misaligned incentive, right? There's sure. reason for the PBM to approve them, because they're making rebate dollars off of all those claims, plus spread pricing, plus an admin fee. Again, there's a million different ways. But just like I said, I think that's the main takeaway, I guess, from this, is that it is our duty, our responsibility to educate employers, city commissioners, school board members, county commissioners about prescription spend and what's happening in the marketplace right now. Because whether we like it or not, independent pharmacy has been under attack for the last decade. There's a reason that so many independent pharmacies are closing. There's a reason why all independent pharmacies are trying to focus on everything and anything besides filling a prescription. We are, basically being exterminated by PBMs right now. And so we have to start fighting back at some point, and I guess OreadRx is my way of fighting back, and trying to educate our local leaders about, why there's a different way to do things.
Awesome. So if Will's Pharmacy is taking the guys from Darren's Hardware, and we're gonna go barbecue this weekend like we do every weekend or whatever, what should what's an actionable item? Like what should I tell them? Hey, you've complained about your healthcare spend and your budget for next year. Go talk to who?
Yeah. So I think the first step where we've seen the most success is have whoever helps you, whoever your HR people are, or whoever your broker is, whoever helps you get into your health insurance plan, have them talk to us, have them talk to OreadRx. We love, our company is maybe even more of like an investigative company than anything. Like we love to help unearth or expose some of the bad things that are going on. And, sometimes the broker may not even know it's happening, it is the bad thing. And so just have that employer, whoever that employer is, whether it's Will's Pharmacy or Darren's Hardware, have them talk to their broker and say, hey, I'd like to look at self-insurance, and I'd like to have you talk to a ex PBM. It doesn't have to be us. We would love to do it. But if you have another local PBM that you trust, then have them look at it. Now, I'll preface that in saying that you need to make sure that you know what that PBM is doing, because it's sickening how many different ways there are to hide stuff from people. And, so just make sure that you're partnering with the right person to do that. But I don't know, time and time again, when we have conversations with brokers, we're able to show them, what's happening. And then, that transitions into a talk about self-insurance. And then, here you go. You start seeing decreases in your premiums instead of increases. So
I imagine, like any other industry, if you have a broker who's been doing the same thing for so many years, it's like, no, this is the way we do it. It's the way we've always done it. And every now and then that complacency needs to be shaken up a little bit. Look out and see what's changed, see what's out there.
Absolutely. And that's a big red flag. So if you talk to your broker and they say, that won't be a good deal, then that's a red flag for you. Like, they should always be looking at that. Like, because you're right. That's one of the things. They get paid no matter what happens. They get a fee from you no matter what's going on. And so this is more work for sure, but it's also going to be better for you in the long run. And so making sure you have a broker that is really working for you and not the other way around. And make sure they're not getting a fee. Ask them point blank, are you getting a fee per prescription? Just ask that question. And if they are, I would look somewhere else immediately. And so like I said, we have really good relationships with national brokerage firms. And so, just give me a call, shoot me an email. I'd be happy to point you in the right direction.
Awesome. Is there a website or a phone number you want to drop out?
Yeah. So, you can, www.OreadRx.com is our website. And so you can contact us through there. You can also personally email me. It's my email is Dared. It's DARED at OreadRx.com. And like I say, I would be happy to point you in the right direction.
Awesome. Can you spell Oread as well?
Yeah, sure. It's OREAD. OreadRx.com. Yeah, thanks for clarifying that.
Maybe some interesting variations out there.
Yeah.
I'm going to let you get back to changing the world, and hopefully I'll see you on here really soon. I'd love to have you on here in a couple of years, and you can tell me about how this is, helped so many thousands of people every day. So
I would love the same thing, Will. and I appreciate what you guys are doing on the podcast. I listen frequently, and I love your content. I love the easy way it is to talk to you and everything. So I appreciate it.
Awesome. Well, thanks for joining us. I'll talk to you soon, and hopefully I'll see you out at maybe Connect here soon.
Okay. Yeah. Sounds great, Will. Thank you.
Thank you for listening to this episode of Beyond the Scripts, presented by the Catalyst Pharmacy Podcast. If you enjoyed this episode, please support our channel by liking, subscribing, and clicking the notification bell so that you'll be notified anytime we post new content. To stay up to date with all of the latest independent pharmacy news and content, follow PioneerRx on your preferred social media platform.